Well, I think in Alzheimer's we are moving in directions that cancer and other diseases have already moved in, which is that we recognize that a patient has symptoms that are the way the disease affects them. And because it's a progressive disease, the symptoms go through different stages of impairment, so that there are stages of impairment, sort of going backwards from a dementia stage where a person is unable to do things for themselves to a prodromal or mild cognitive impairment stage where they're having symptoms but they can still do things for themselves, all the way back to a so-called preclinical stage where people have the changes in the brain but don't have any symptoms yet. As in cancer, where you can see the changes in the relevant organ in some cases, but the person doesn't have any symptoms. So one of the things that is a theme that's emerging, I think, is that even though we need to enroll patients as groups in clinical trials and compare the active treatment to the placebo, there is an increased ability, I think, to personalize the targeting of patients to clinical trials and ultimately care and treatment of patients based on their own profiles. And some of those profiles include cognitive functioning or behavioral symptoms, what exactly they're having trouble with. And that relates to the problems in the brain that we can measure with imaging. And ultimately that refers back to problems in the molecules, tau and amyloid and other molecules that we can measure with imaging or sometimes in spinal fluid, and that are increasingly being targeted for treatment. And ultimately that may be influenced by different genetic factors that people have. So I think there are a whole range of levels of measurement that we have that are enabling us to be able to personalize our care and also the research that we do with patients in a way that other fields have found productive.